All right, good afternoon. Welcome to the School Nurse and Hospital Partnerships for Patient Reunification webinar, hosted by Western Regional Alliance for Pediatric Emergency Management, or RAPM. Hi, my name is Larissa Chiari-Keith. I am the Southern California coordinator for RAPM. Before we begin, just wanted to let you know that the RAPM is funded by the Administration for Strategic Preparedness and Response, otherwise known as ASPR, and the contents are solely the responsibility of the authors and do not necessarily represent the official views of ASPR or the Department of Health and Human Services. Before we begin, the webinar is being recorded for future viewing. Please submit your questions using the QA feature in the Zoom. And for those of you who are able to access the chat, we'd love to know where you're calling from or connecting from, actually. We are expecting about 300 participants from across the country and perhaps internationally. So if you could put your name, your agency, and your city and state, we'd love to know where you're coming from. For any questions regarding today's session, please contact our team at Larissa, Larissa, at ala.la, which is me. A little bit about Pediatric Disaster Centers of Excellence. We are 3 Pediatric Disaster Centers of Excellence. We are funded by the Administration for Strategic Preparedness and Response, as I mentioned, ASPR, and the objective is to bring together children's hospitals, private and public entities, and national organizations to share best practices in pediatric disaster preparedness, response, and recovery on a regional level. The 3 Pediatric Disaster Centers of Excellence are Gulf 7 Pediatric Disaster Network, which was awarded in 2022 and anchored at Texas Children's Hospital in Houston, Texas, and encompasses the 7 states of Alabama, Florida, Georgia, Louisiana, Mississippi, Texas, and Puerto Rico. Region 5 for Kids was awarded in 2019 as anchored at Rainbow Babies and Children's Hospital in Cleveland, Ohio, and covers the 6 states of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And then RAPM, which is where we're from, is the Western Regional Alliance for Pediatric Emergency Management, was awarded in 2019 and anchored at UCSF Benioff Children's Hospital in Oakland, California. And we cover the 6 U.S. states of Arizona, California, Nevada, Oregon, Utah, and Washington. I'd like to turn it over to Bridget French from Pediatric Pandemic Network, who is the one that brought us this idea and connected us with Chris and Shadley. Take it away.
I'm thrilled. Thank you, Larissa. And it wasn't just me. This is a whole team, but I've known Chris for a while and he's truly Superman, and I'm thrilled to introduce both Shadley and Chris to everyone. They're 2 of the best people on the planet. So we'll start with Shadley Kensrue. She's serves as the Director of Health Services for Irvine Unified School District and brings nearly 20 years of nursing experience to her role. She oversees school-based health services and programming for approximately 38,000 students across 43 schools and supervises 28 registered, credentialed school nurses and 43 health assistants. She's also a former critical care and trauma nurses, and she's led district-wide health initiatives that are focused on emergency preparedness, prevention, and system level innovation. She co-chairs the Emergency Preparedness Interagency Collaborative and the SHARE program, which Chris and Chadley are going to tell you a little bit more about in their presentation. And Chris Riccardi, special place for you in my heart. He is the manager of emergency management and business continuity for Rady Children's Hospital, Orange County in Orange, California. His responsibilities, among so many other things, include the development, implementation, and management of emergency management planning and exercises, and of the enterprise-wide business continuity program. He also is co-chair for the EPIC Collaborative and the SHARE program, and he serves as the chair of the Southern California Pediatric Disaster Coalition.
Thank you,
Back to
Bridget.
you. Yes. Yay.
Chadley.
Yeah, go ahead, Chris.
Well, greetings all. Thank you, Brigitte, for the wonderful introduction. You know that feeling is truly mutual. It is such a neat opportunity to be able to partner with such amazing people. Uh, it's we've been working on a really cool project. My introduction basically is that I do manage our emergency management business continuity program, but one of the really cool things that I've been doing as of late is to be co-chair with my co-chair extraordinaire, Shadley Kensrew, of our SHARE program, which is the School and Hospital Partnership for, or the School and Hospital Alliance for Response in Emergencies. This has truly been a passion, labor of love. We found a neat pathway that we're looking forward to sharing with you. And I, again, over the next 45, 50 minutes, we're going to be sharing a whole lot of information, impart some wisdom, knowledge, and of course, resources to you before we part ways today. But just because of that, just know that we will also be available to you in the future as a resource. And before I get too far down the line, I will pass this over to again, my co-chair extraordinaire, Shadley Kensrew.
Thank you, Chris. I think that's becoming an official title of lately, so thank you for that. It's really exciting to be with you all today. I cannot say enough about the relationships that have been built through our School and Hospital Alliance for Response in Emergencies, not only here in Orange County, but as this has spread now today nationally, and Brigitte and Larissa and all of the wonderful people that I've met along the way. We just continue to learn more and grow more and be able to bridge a lot of needs between schools and hospital response with pediatric emergencies. So we're super excited to present our work today. I'm going to start us all off today. I'm also controlling the slides, so let's see if we can get these going. Perfect. And we introduced ourselves. So as we begin the conversation today, I encourage you to have a scenario in your head, as it will give us some context for our discussion today. The scenario I want you to have in your head is a two school bus collision that occurs on a major freeway. And we'll talk more about utilizing this scenario for our own group in the future. Aboard those two buses are approximately 80 passengers, both adults and children, but mostly children. And because of the accident, there's a plethora of injuries ranging from minor all the way to very severe traumatic injuries. And those patients are transported via EMS to a variety of hospitals across county resources. So have that in your mind as we go into our discussion. We know that unfortunately this is not an uncommon event. This specific photo in the slide here was from Shreveport, Louisiana, last January, where this was a real life emergency. And because of emergencies like this, we have learned a lot. We've learned that there's a lot of gaps, and Chris is going to talk about some of those findings.
Thanks, Shadley. So what does this look like? And I'm going to go at this as from the perspective of being the only pediatric hospital in all of Orange County. We are a county of 3.3 million people, 800,000 of them are pediatrics. I think you can understand the gravity of what we're dealing with here. But understanding what the nature of these injuries, what the nature of these accidents and events may be, that it is my expectation, and I think the statistics will demonstrate that 63% of the parents will just start to show up to find their children, whether it be going to the school, going to the hospital. They're going to go directly to retrieve their kids. They are not going to wait for somebody else to assist them. They will take matters into their own hands. And that is even in disregarding any evacuation orders. But I expect to see them, and our planning is based around them spontaneously reporting to the hospital to find their children. And again, being the only pediatric hospital in the county, my expectation is we will be that beacon and those folks will show up here. And then in moving forward with some of this, understanding the unique reunification challenges. We deal with, well, in that scenario alone, we're dealing with a number of victims. Some are communicative, some are not. And if you show up in our facility without being non-communicative, maybe nonverbal, unable to identify yourself, you're going to be assigned a DOE naming convention, whatever that may look like. And we deal with this on a regular basis. But the point is that there are going to be a whole lot of DOEs in my facility that we're going to need to work through. We deal with EMS out on the scene, assisting us with these processes, triaging these folks out in the field. And they try to assure us that we will receive victims with names, etc. But on a good day in my ER, we do not necessarily get that information. So we have to plan for those gaps. We have to plan for those eventualities, plan for any shortcomings that may be in the process. And remember, some of these folks are going to be critical what that may look like. We've seen in events past that that is in fact the case, especially if parents go and find their kids at the site of the event to grab their folks and bring them to the hospital. So younger children are more likely to have difficulty self-identifying. You ask a 5-year-old what their mom's name is, they'll tell you mom, or dad is just dad. This can be a little challenging to say the least. But working through some of this, we have various folks that can assist us with trying to get to the bottom of some of those questions, but not all may be able to provide that information. We've learned that following the Uvalde shooting, it took more than 12 hours for all of these families to be reunified or notified of their child's status. Now, I don't know how you feel about this, but if those were your kids, you think 12 hours is an acceptable option? It's definitely not to me. And as a person who is in charge of our emergency management, our business continuity, how do we maintain our face and our trust within our community if we're unable to put programs and processes in place to assist my community in a time of need? This is the practical side to business continuity. And as we continue to work our way on through, the delayed reunification leads to various issues psychologically, the psychological distress for the children, and of course the families. Now, mind you, these families are showing up at my facility looking for their kids. We can't, if we don't have answers for them, how calm do you think they're going to be? We've all seen video of people showing up at the airport to get on a flight, and their flight is delayed, and you see how folks may get. Now, imagine not being able to find your child, or me not being able to give you information as to where your child is. That is, again, an unacceptable option to me. Sorry, my lights are on a timer and they all just faded out. It's not your lack of lunch. I'll try to move around a little bit and try to get them back on, but we'll see. Just moving my lips apparently does not turn my lights back on. So I apologize for that. Just know it wasn't you fading out on me. So family members, again, they're going to woohoo, illumination. So these folks are going to start arriving at the medical facilities frustrated, in anguish, of course, and they are going to try to work their way on through. They want to know where their kids are. So beyond the emotional side, you got the long-term and profound impacts on the kids. Think about the psychological stress on these kids, being separated from not only their parents, but also the school. Now, remember, this was a field trip. These kids are on a bus with schoolmates, with teachers, with caregivers that were on that bus with them, and now they are separated from them. They're in a big, scary hospital, a whole lot of doctors and nurses that are working around them, trying to help them. I think you can also have a little empathy, sympathy for what they may be going through. So how do we assist with that process? And again, part of that mitigation is realigning them, reuniting them with their families. think about, and now from a business side, you think about the delays that would relate to, well, worse health outcomes, only because they are obviously not in a place to psychologically get better. And I don't mean just even psychological care, but even just to be in a place emotionally to be able to work their way on through some of this. And then, of course, there's going to be extended stays in my facility, which of course, are increased costs to the families, to various things. And but besides the money aspect of this, think about the personal side of this and what the trauma will be for somebody stuck in a hospital bed for 4 or 5 days longer than they need to. And being separated from their families, if we're even able to identify these folks to reunify. Imagine if we don't have that information and we're working through Child Protective Services. And we'll get into that haranguing here momentarily. So, where is the gap? Well, we found that there is truly a lack of coordination between agencies. Some facilities, some regions, we don't even have a bona fide family reunification program plan in the county I live in. So, how are we going to manage through some of this? So, part of what we've developed working with Shadley and our share team is to develop a process to circumnavigate that hindrance. How do we work our way around this problem? I cannot just say, oh, my county doesn't have a plan. Oh, well, we'll just worry about that later. That's unacceptable to me. So these solutions have been put into place to mitigate that gap. Well, first we identified that gap. Second is to put those plans in place based on existing data. And how do we unsilo these plans that are being developed? And one of the things that we truly learned was how much work was being done in the school districts around reunification. And of course, the work that we've been doing in the hospital. And what I mean around the work at the hospital, I have tried to avoid using family reunification from cutting my teeth in emergency management only because of the extra burden on the hospital to be able to find this information, working with Child Protective Services to identify custodials, to identify different needs. How do I identify these kids? Well, that perspective has truly changed because of a bridge that has been developed and the missing link that was uncovered. And with that, I'll hand this over to Shadley to share part of what we have determined.
So as Chris said, we think we have uncovered the missing link and something that will lead to improved outcomes, decreased costs, and decreased chances of a secondary psychological injury from an already very stressful and traumatic event. So school nurses are quite possibly the missing link between school-based emergencies or in school-based emergencies between hospitals and schools. School nurses are uniquely equipped for this role because they are familiar with hospital systems. Most school nurses come from some clinical background like mine in trauma and critical care. Most school nurses have some training and some experience with trauma-informed care. And really the magic of it all is that school nurses will be able to navigate these systems, understand what's going on, and then provide a beautiful gift, which is the student information system, to help with the reunification and identification efforts happening at the hospital. So how did we get this started? This is a photo of us when we first started. Our group was very small but mighty. We had a lot of wonderful experts in the room when we first started this group about 1.5 years ago. And this all started because here in Irvine, Dr. Stephen Bain there on the left, the far left there, he started something about 15 years ago called the Emergency Preparedness Interagency Collaborative. And it's a committee of partners within Irvine and around the surrounding area of Irvine to essentially plan for large-scale emergencies that might impact our school district. And we've since involved charter schools, private schools, higher education within the boundaries of Irvine. And I was invited to participate in that committee early on in my administrator career. And one of those questions that Dr. Bain and or that I posed to Dr. Bain was, we are doing such a great job of planning for reunifying families at the school site in the event or off site. But have we considered what reunification is going to look like once students are transported via EMS to the various hospitals in the county? And how are we going to support families when we don't know which hospital they went to? And that question alone started a very quick progression into what then became the subgroup of EPIC, which was our hospital liaison group, was what we were calling it in the beginning. And the initial idea was, how can school nurses from the Irvine area, our school district, and the surrounding schools, how can we partner with hospitals in our area to support the efforts of identification and family reunification if there was a large-scale emergency? This is when Chris Riccardi entered the scene and was introduced to me by Dr. Alma Sheikh and a couple other people on this committee. And Chris and I were kindred spirits and both had a shared passion and vision for this project. And we were able to start with this small group and eventually realize that this really did need to become a countywide effort. We have 26 hospitals in Orange County, California. We have 28 school districts of varying size. Not only that, but we have secondary education, Cal State Fullerton, UCI, several private universities in our area. So we knew this was much bigger than the boundaries of EPIC and the Irvine area. So we branched out and invited all 26 hospitals, all 28 school districts. We now have representation in our group of our charter schools, our private schools. And this work really started around sharing a vision, developing plans, and really kind of just open dialogue between everyone on what plans were being implemented in the various places and how could we partner with each other to create some kind of system where we could collaborate in an event like this. This eventually led to us growing and becoming the School and Hospital Alliance for Response in Emergencies. And it's only been a year and a half, but there has been tremendous work that has happened, and we're super excited to share kind of the nuts and bolts of that as we move on here. The main three focuses the main three items we focused on once we got all of the stakeholders in the room were communication, developing comprehensive plans, and integrating our reunification efforts. And a large part of that has been our work with Orange County Fire Authority, the varying hospitals and trauma centers, the school districts, and really it's the work with the emergency managers at that hospital, or at those hospitals. So Chris has been amazing. We've had a lot of great shared conversations, and me learning more about what's happening on the emergency manager side, and him learning a little bit about what school nurses do and what we can provide.
And make no mistake, I have a whole new appreciation for school nurses. Make no mistake about this. I have been welcomed into their family, and they've taken me in and have opened my eyes to a whole lot of what they do. And I could not be more grateful for what they bring to the table. Working in a hospital, we have a tendency to see the world from a hospital lens, but we're working with the school nurses. I get to see what the hospitals look like from outside of our walls and how we can support those community efforts, etc. One of the early things that we did learn was the need for communications, and to how do we enhance the communications between both the schools and the hospitals and vice versa. Well, obviously, developing these relationships was critical. We started with monthly meetings, in-person meetings that help to establish a relationship, not just an email process, but actual having a cup of coffee, having conversation, cross tables. We started off pretty, I think, probably about a good dozen, 18 people that has now branched out to, well, we need bigger space for our meetings these days. I'll just leave it at that. especially bringing in our higher education. And I'll cover a couple more of the challenges with that or why we need to worry about higher education here shortly. So, what are those familiar communication channels? How do we communicate? Early on, Shadley and I last September, we presented this information to the California Hospital Association Emergency Management Conference. Right 3 weeks prior to our presentation, there was a school shooting in Minnesota. And because of that, I also chair a national PEDS coalition that we meet. It's a very relaxed environment. We get to share, commiserate, et cetera, et cetera. But one of my peers in that group is a gentleman up at Minnesota Children's. And we had a little chat. I wanted to run past him things that we had encountered, what we were sharing, and what we developed to see if those would have been true tools that could have been utilized in his response. One of the key findings was they had no contacts at the schools from the hospital. So they had no idea who they needed to communicate with at the school level. And the schools had no idea who they needed to communicate with at the hospital. Well, we've been able to bridge that gap with what that would look like. Early notification, and we'll cover a little more of that because if an event happens at the schools, Shadley knows to give me a call, let me know, Chris, look, heads up, things are happening here. You're probably going to get victims. There are multiple casualties. It gets me into my response phase. We have a program here that we utilize called 15 minutes till 50 patients, a neat way to manage our MCI. But imagine having even extra time on the front end to be able to be prepared for the influx of victims. So if Shadley calls me, I can initiate that process with my house supervisory team, with my emergency department team, to prepare us for what is coming. And because I may even know of the event that took place, to even prepare for the types of injuries that I may encounter when they do get here. Imagine having that kind of time and that much of a heads up. But by having those relationships between the two of us, now Shadley may not be the individual that comes here to assist us, but she has my number, and I know that if she calls me and tells me something's happening, she's a trusted partner and I can trust that her whatever she's encountering is severe enough for her to call me. But now, if she would have just called the hospital and spoke to a house supervisor or one of my nursing leaders, they wouldn't know who Shadley was, unfortunately, because everybody needs to have a Shadley Kensrew in their life. I can tell you that for sure. And I've learned that early on as well. But again, if she would call my hospital, folks may or may not even know who she was or poo-poo whatever information she's providing. But if she notifies me and I notify those folks, we've just changed that relationship and it is now a bona fide response. So we've updated our contact list. We are now all familiar points of contact. One of the other cool things is I've hosted meetings at my facility because we go through a pretty rigorous check-in process at my hospital for anyone obviously protecting the kids, working through Megan's Law database, etc. But now they are all established within my registration system. So that's a huge help in terms of our communications. And what we deal with next was the next phase of this was to develop comprehensive plans. Those plans needed to be put into place to document what we do. We built an MOU, Memorandum of Understanding, that basically is the outline of roles and responsibilities for both the educational entity representatives. We started this off very early that we had to come up with something other than school nurse because not every district may utilize their school nurses for an event like this. So we had to utilize the educational entity representative, and that has worked out pretty well. It's pretty much a blanket statement. So as part of that MOU, we have roles and responsibilities. What would this look like? How would this roll out? And of course, with our higher education folks, we deal with a few different nomenclature issues. So we've been trying to be all inclusive of how we manage through. I've gotten a whole new education. And again, by having these plans also defines how we would, one, well, let me start with this. Any of you have well, in healthcare, understand what HIPAA is, right? We have that Portability Privacy Act. Can't be putting out people's health information. Well, on the school side, there is a process called a regulatory compliance factor called FERPA. I learned more about FERPA in a year and a half, and living in the regulatory and accreditation compliance world, needing to understand FERPA. I've gotten pretty savvy, but one of the things we needed to establish was what would be the trigger for us to be able to share information across the entities. Now, I don't need to tap into Shadley's system. She doesn't need to tap into mine, but what would be the trigger for us to have the authorization to release that? Well, under both HIPAA and FERPA, FERPA especially, that if we declare a disaster or something is defined as an emergency, we can share that information based on their compliance, their regulatory compliance. Now, what designates an emergency? Well, we needed to establish that as well. And it was pretty simple when you really start to think about this. It was established within the schools that if they call 911, that is now an emergency. That has just freed up the opportunity to share information across the miles. So FERPA, HIPAA kind of get joined at the hip. We definitely are looking at things from the same perspective, ensuring our regulatory side is taken care of, the legal side is taken care of. And remember that your school nurses, your school folks, your educational entity representative is also the custodial for your kids before the parents show up. So you have a resource available to you that, folks, you need to know your school nurses. You need to get yourself intertwined with your local school districts. Uh, with and by having these comprehensive plans, now the different school districts, that's great. We have 28, as Shadley had mentioned, not to mention higher ed, as well as our private and charter schools. But all of my other hospitals, all they need to know is the school district that their hospital is within. Being the only children's hospital in all of Orange County, I need to have relationships with all 28 school districts. I need to make sure that they know me, I know them. And of course, the higher education side, this was the thing that was a very eye-opening for me. I figured, all right, I'm off the hook with higher ed. What do I really need to worry about as a PEDS hospital? Well, it turns out that each one of these facilities have some type of childcare, daycare center on their site. They may have anywhere from 30 to 150 pediatrics on their campus at any given day. So, needless to say, just when I was starting to sleep with both eyes closed, I had to start with one eye open. And that's not to mention the fact I have this small amusement park around the corner from my facility called Disneyland that may also impact my process as well. So how do we integrate this stuff? How do we build our disaster plans? We built a charter to assist us with that. And then how do we integrate our reunification process? You know, it works out pretty well. Part of why we are doing that here, again, there is no family reunification center plan in my county. So I can't rely on somebody else. We had to build this stuff from scratch. We're literally on our own and only as strong as my community partners. So what does this look like? Integrating that reunification process. Ooh, did everything get dark on you again? We're good. Sorry. I have no control over this motion sensors that are in my lights. We just improved our lighting. So thank you for chalking that one up for me. So in integrating the reunification process, I no longer have an issue with calling it reunification in my hospital because I get the support of my school nurses. And Shadley's going to share with you in a little while about what that process looks like. But we had to overcome these challenges. How do we identify these victims? We did a tabletop exercise just recently to validate and integrate much of our processes. And again, to update the contact info to custodial folks using the student information system. Folks, if any of you have kids in school and you're required to update your student information system, I'm going to tell you from a reunification perspective, as a parent myself, as somebody who is looking out for your kids, please update your student information system information when you're asked to do so. That could be the difference between you finding your child or you not finding your child. And by the time we get to the end of this presentation, hopefully we validated and verified that precise statement. And with that, I'll turn this over to Shadley to demonstrate what this the hospital response reunification process looks like.
All right, so I've put a flow chart up on the screen, and let me explain it before we get into the details here. The top red portion is the hospital response in a large-scale emergency involving a school. Down below is where our school nurses or our educational entity response folks could fit into this situation and bridge that gap. So to be clear, as much as I would like to see if I still have my trauma nurse and critical care skills with me, we are not proposing that school nurses get involved with direct patient care. What the school nurses would be doing, or the educational representatives, we would be providing information. Going back to our discussion on how this group started long, a year and a half ago. I say long ago, it really wasn't that long ago, but there's been a lot that's happened in a year and a half. One of the questions that the hospitals kept proposing is, we can't give you this. There was some hesitancy there. And one of the school nurses in the group said, we're here not to ask you for anything. We're here to give you something. So I'm going to show you all the gift that school nurses can provide in this situation. So let's work through it, starting from the left to the right. So a school-based emergency has been declared. We'll use the bus scenario again here. In that moment of time, I can use my updated contact list from my share group to then call the local hospitals and trauma centers to give my contacts and some early notification. But I'm not sure the details, but I know that there's been a bus accident involving 2 of our buses on their way to a field trip. And I know I've got about 80 or so students on board those 2 buses. That information, as Chris said earlier, could provide him some really crucial moments to get his hospital set up, his ED ready to receive a large number of patients in a short amount of time. Additionally, at that same time, I could then contact my team here in Irvine Unified and deploy my school nurses that are on this team to report to their pre-assigned hospital. Now, here in Irvine, as we mentioned, there's 28 school nurses that I supervise. There are 7 of our nurses who are on this team who know which hospital they would go to. From the second I send a text or a phone call, they would grab their laptops, they would take their equipment, and they would head out to their hospital that they've been assigned to. Once they arrive at the hospital, the school nurse or the educational entity representative will integrate into the Family Information Center. So hospitals typically set up a Family Information Center or Family Reunification Center in an event where there's a mass casualty incident or a large number of patients coming to the hospital. This is the perfect place to put this person. Because what they're going to be doing is helping receiving the information coming in from the hospital staff and using the student information system to cross match that information with their information. So this is where the magic happens. Below again is the blue is the school nurse or educational representative. They are using their laptops and the student information system to cross-match the information coming in from the hospitals and the identifying information on those forms to link up with their class rosters or their class photo lists. And here in this next slide, the form below or behind in the red is one of Chris's unaccompanied minor forms that they use in an incident where we have unaccompanied minors. For this specific patient, we did not have a name because they were nonverbal at the time they were admitted to the ED. But we do know that there is some identifying information here. Now, I, as the school nurse, can look up in my student information system. I know that on those 2 buses, there were 2 classes that were part of that. There were 2 science classes from these 2 teachers' classrooms. I can pull those rosters up. I can look at photos and I can cross match who that patient might be based on my photos. Once I make the match, I can then pull up critical medical information about that student, and I can also pull up all the caregiver contacts. In addition to that, our student information system also has legal information if there's a restrained parent or if there's more information there that would be helpful in reunifying that family. That information is available to the school nurses. The last part is what we would hope for all of our patients that would be in this incident, is that they would eventually go to be identified, reunified with their family. We would care for them in the hospital and they would eventually be discharged. And this partnership between the schools and the hospitals can also enhance the discharge planning at the end of their hospital stay to make sure that our school resources and our hospital resources are combined to ensure that we are supporting this family beyond their discharge from the hospital. So does it all work? Chris is going to tell you about our first tabletop exercise that we've just had.
And when Shadley says that the student information system is a gift, make no mistake, this is truly worth its weight in gold. And how we've been able to work together. And when I first saw it, my jaw hit the floor. Took a good 10, 15 minutes for it to be retrieved. But when I got to see the information that was available to us. Now, mind you, Shadley had a plan to send her staff to me to assist me and my hospital. They didn't want to take anything. They wanted to give us stuff to go back and rehash that one. But it's neat to be able to have that kind of support. Now, mind you, the expectation is not that they're going to be involved in any patient care. They're going to be strictly here to assist us with the reunification process. They at least have an understanding of hospital workings. Many of them come from the hospital environment. So that is a very big plus. So our tabletop exercise was based on that dual school bus crash. And as we went down that path, our first responders quickly declared a mass casualty incident due to the number of PEDS patients and what that on-scene triage was, the mechanism of injury. So we were able to receive a whole lot of information from one. We are a base station, so our EMS agencies notify us of when they're on the scene. But if this would have happened at the school and Shadley let me know 10 minutes prior, because by the time EMS gets on scene, 5 to 10 minutes before they make base contact, another couple of minutes beyond that, we are already 15 minutes into an event where those are critical minutes that I could be doing a whole lot of work here to support her and her students and her team to accommodate, even to prepare for her team showing up here to assist us. So in doing so, moving on into our key details. So we used approximately 84 students that were on the buses. 15 of them were transported to the local trauma centers and hospitals, and we utilized the different hospitals and teams in the room. We also utilized our communications team under the Emergency Preparedness Interagency Collaborative to help support and identify how to message out to either the parents or our community of the events. Parents start calling 911, the school district, and the local hospital seeking information. As we've seen from Sandy Hook or Marjorie Stoneman Douglas, parents just report to these facilities. Same thing with Uvalde. You remember all of those people, the parents that were standing outside that school. It breaks my heart just thinking about this. How do we mitigate that from happening again? Now you're dealing with media helicopters as well, arriving on scene. This is where our public information officer folks got involved. And then we get into our key objectives. And the main objectives to what we did was how do we receive early notification of the MCI? What internal activation steps occur? How do we track the pediatric patients during rapid intake? What documentation? We had conducted a complete full-scale exercise in October with 140 victims, so that part of the purpose was for my partners in the share environment to be able to see how the hospital receives victims, what that looks like, and how we're able to manage. Well, out of those 15 individuals that were non-communicative, over the course of our hour exercise, we did not do any, not playing any different games, not any different types of assumptions. We were able to identify all 15 of those kids just based on, again, no names on my sheets coming in, whether they be DOE convention or otherwise, and the student information system that was incredibly helpful. But again, the strong cross-county representation from the schools and the hospitals, the meaningful connections. It would not have happened without those connections around the table, and of course the exercise environment that truly encourage an open dialogue. All of our exercises, everything we do needs to be based on improved communications. And if that means open dialogue at the table, then so be it. And with that, we'll keep on moving to advancing our work. And that is, we're going to continue on down this path, continued development of our process, integrating the communication processes, identifying clear processes for the school reps to integrate into my hospital, address the cross-jurisdictional challenges. Look, we're dealing with multi-agencies. How do we align these things? Understanding the legal haranguing was half the battle. And expanding participation from our additional agencies. I think we have been on an incredible journey. We've been working at breakneck speed, but finding the support of our PPN folks, our RAPM folks, all of our local community, et cetera, seeing the value in this has been a true treat. And with that, I'll let Shadley share with you how you can replicate this in your own environment, and we'll keep moving right along here.
All right, so like Chris said, we moved at tremendous speed with this amazing group in the share committee. And we've created some resources to help you replicate this wherever you're at and hopefully whatever state you're at, and whether you're coming from a hospital setting or a school district. There is a website, it's under the Epic Irvine.org website. There is a share button in the upper right-hand corner. And we have shared the MOU template, the flow chart, our charter, everything that we've created is there for your use. And we are hoping that if you do replicate in your area, that you will keep Chris and I informed of your progress with that. We would love to hear how it goes. We'd love to hear about any challenges that you face so that we can continue to work this forward. We're so excited to have a national representation of this out there and see how it goes in the various areas. So with that, we'd like to open it up for any questions that you all may have for us.
I don't have, before we get started, with all my heart, I want to thank both of you. You really are the A team. And Chris, you say all the time, everybody needs a Shadley. Well, everybody needs a Chris too. Everybody needs a Chris and a Shadley in their lives and their organization. So just thank you so much. Larissa?
I echo exactly what Bridget said. We need both Chris and Shadley. Thank you so much. This has been incredibly informative, and I have some questions for you if you're ready for them. The first one is Share already connected to the National Association of School Nurses?
Funny you mentioned that. So I do have a couple contacts that I have initiated with NASN, and there is discussion about publication in NASN magazine. So be on the lookout for that. Chris and I did just present in Monterey at the California School Nurse Organization conference in, goodness, when was that? February. We've been doing a lot of fun things lately. So that was in February. We did not miss the window for presenting at NASN in Vegas this July. Plus, I'm not sure I could get Chris to Vegas in July, maybe, but next year it's in Louisiana, so maybe we can present at NASN next year. That would be the hope. So yes, NASN is aware of us, and we're hoping to present at NASN soon.
And I can
Perfect.
assure you that after spending a little time with school nurses at their conference, any conference in the future, I am all in. And it does not matter what city it may be in, and I'm game.
Okay. If you deploy your school nurses to the hospitals in an emergency, who is providing health services to the students at the impacted site or at the schools with students who were not impacted?
Absolutely. Great question. And actually, that was supposed to be one of my points that I hit on in discussing the deployment of the school nurses. So the site where the event took place, that school nurse would not be leaving the site if they were on site. That school nurse would stay on site to support any medical needs. These would be nurses that are not, you know, immediately involved in the incident. They would be at other sites or, you know, district office and be able to be deployed.
Perfect. Okay, so this one's from Rachel Mazzara. She says, if this event happens in the community, for example, during summer or non-school hours, would you still be able to call upon the school nurses to assist?
Let me take that one. I would at least make those phone calls. Not all schools are off for the summer, I've learned. Not all individuals from the schools are off all summer, I've learned. And I don't know if that's a Shadley specific thing, but I do know that she seems to work throughout the summer as well. But it's those contacts remain true. And whatever that may be, even if they may not be in session, they may be able to put me into contact with somebody who can assist me at that point. That is the benefit of having that interactive and integrated communication process.
Perfect. Okay. The next one comes from Pat Frost. Is your activation criteria memorialized in your MOU?
Good question, and Pat, that's pretty awesome. And thank you for the support here as well. The triggers for this are going to be incident specific. It's not necessarily the numbers, but maybe the nature of the injuries. Whatever may be overwhelming to the school would then be notified, would make notification to me or our EMS agency responding on scene to identify the magnitude of that event. We in our hospital, if we were going to deal with a 10-person influx, depending if there were minor injuries, we would not activate our external triage process. But now, if we dealt with 10 to 15 traumatic injuries, that would be a different trigger for us. So, although there may not be a defined trigger for a number or an event, it is more based on the magnitude of the injuries and the situation taking place. It's difficult to define with so many different variables that could be involved with that. But great question, Pat.
So the next question is, did you work with local emergency management agency? This is coming from Amy Seward. She says, we're a small county and she is county EMA organizes a P20 group with local law enforcement, first responders, school, hospitals, K-12, and college, university.
You want me to take this one?
Sure thing. Have some fun.
We have had the privilege of having one of our Orange County Fire Authority administrator captains, Captain Ryan Kames, be in our group from the very beginning, and the knowledge and the partnership that he's been able to share with us to help us understand how, you know, what our process could be that would intertwine with how OCFA runs their mass casualty incidents. Yes, so yes, they have been involved and have been very helpful in determining some of our processes and identifying some challenges that we didn't think about initially. So yes, that would be a key player in that stakeholder group.
And remember, one of our key functions is to break down silos, right? And there are different moving parts involved with this that may or may not be under our purview. And this is where our EMS partners come into play. We're involved in tabletop exercises throughout our community. I'm a member of the larger EPIC group as well, help facilitate some tabletops, been a participant in tabletops. We need that cross-pollination, if you will. We need that cross-agency integration, collaboration. This is truly exemplary of the strength and power of collaboration. So yes, and if we identify a gap, just like I am a gap, the hospitals were a gap at the beginning of this, and through Shadley's vision and questions, well, brought me to the table to be able to represent our hospital side of things, to be able to start to fill that process and de-silo. I don't even know if that's a word, but it sounds really damn good. That we can keep breaking those down and keep moving forward, again, through collaboration.
So the next two are regarding players as well. So I'm just going to combine them. Did you incorporate your healthcare coalitions in the process? What role did they play? And did you incorporate Red Cross?
May I take that one, Shadley?
Yes, please.
We've tried. Well, actually, I'm involved with EPIC because of my healthcare coalition and Dr. Alma Sheikh. But and we've been supported by Dr. Sheikh and a couple of folks from our agency. But our agency does not have a plan. So the support has come to assist us in keeping us together. But the that's also one of the shortcomings is that there are no foundational process for a reunification process within our EMS or in the agency. And I also am co-chair of our Healthcare Coalition's Hospital Advisory Committee. So there is integration into that. And what was the second part of that question, Larissa?
Red Cross.
Red Cross. Red Cross, and well, we've been more engaged with the United Way. It seems that the United Way is going to be a very big partner for us, working with our one of the higher education folks from UC Irvine, the college campus, as well as the Orange County Department of Education, their emergency manager working with us. We'll be meeting, as a matter of fact, with the United Way in 2 weeks to determine what these processes could look like. They are going to be our community support. As I mentioned, there is nothing that exists. We need to come up with a solution besides just throwing our hands up and saying, "Oh, well, guess the plan's not there. What do we do now?" So we need to have that solution.
I would add to Red Cross is part of the EPIC group, the Emergency Partnership, Emergency Preparedness Interagency Collaborative that Dr. Bain oversees. So Red Cross is involved in that and knows of our work. They're just not involved in share yet.
Thank you for that. And my apologies for the oversight of Red Cross.
So this question comes from an anonymous attendee. How would parents know which hospital their child was transported to, and are there plans to open up a call center too?
Great question. Yes. So if an event like this were to occur, our school district would initiate the emergency operations center at our district office. And part of our plan is that those nurses who are reporting to the hospitals and as they identify patients, we would have a live document going back to the EOC at the district office so that we could be communicating with parents on which hospital we think that their child may have gone to. Once we have confirmation, obviously, then the school nurses or the EERs might be able to even facilitate that communication between parents and the location of their child.
Fantastic. Okay, I'm going to squeeze one last question in. Did any of the improvements you implemented require changes to state or local laws, regulations, or policies?
We did not change any laws, regulations. And again, we're only a year and a half into this. I think we've been moving what the potential is for this response type process forward. Nothing has changed on a policy level. The only thing that hopefully we are making some improvements on is moving our county partners forward in being able to support us in this process. And hopefully, there's that expression about the tail wagging the dog. I'm that tail, and I sure am wagging. And let's see where we can go with this. And hopefully, this can be the impetus for change.
So I'm hearing that there are more questions in the chat. We are going to collect them for you, Chris and Shadley, as well as the two that we weren't able to answer live. And then I am just going to share screen. Sorry, Shadley, to kick you off. Hopefully you can see it. Just as a closing, thank you so much, Chris and Shadley, for this incredible webinar. You guys are absolutely amazing, and we're so lucky to have you involved in RAPM. If any of you would like to learn more about RAPM, join a topic-based focus group, register for our weekly partners meeting, becoming a contributor, an author. We do projects and academic publications and resources all the time. Please contact us at rapam.org or follow us on at rapam. Here is the QR code for RAPM, and also the Pediatric Disaster Centers of Excellence, which I mentioned earlier, we're part of, along with G7 and Region 5 for Kids. Here's the QR code for that one. And I know I'm going quickly. And lastly, Bridget represents the Pediatric Pandemic Network, and their website is pedspandemicnetwork.org.